Okay, so this is chapter 4. This chapter covers assessment, diagnosis, and treatment, and we're going to be focusing on child psychopathology. Okay, so clinical assessment is a process that focuses on differentiating or defining and measuring children's behaviors, their thoughts, and their emotions in the context of their environment. So the differentiating part is important here in terms of thinking about what specific disorder a child may have. And the diagnosis part is basically identifying a disorder, examining the symptoms that the child is presenting with. So the assessment is sort of this more broad process, and a diagnosis is when we're focusing on DSM diagnoses and trying to come up with a diagnosis for a particular child's presentation. Some things to keep in mind when assessing kids for psychopathology. The first one is their age. So different symptoms are more or less normative across different stages of development. So it's important that we think about the symptoms a child is presenting with in the context of that child's age. So for example, tantruming in a 3-year-old once a week may be considered normal, but tantruming in a 15-year-old once a week, we may begin to view that as abnormal or dysfunctional. It's also important to think about gender. So aggression is more common and more normative in boys compared to girls. So that's an important fact to keep in mind when you're doing clinical assessment. We also need to take into account cultural considerations. So one example of this is shyness in Western culture versus in Chinese culture. So shyness is much more normative amongst Chinese people. So if we were doing an assessment, for example, on, let's say, a 5-year-old child who had recently moved from China and was still living with their Chinese family, and they presented with some inhibition or shyness, we may not view that as dysfunctional or problematic in the same way that we might see that as problematic in a child born and raised in America. If you want more information about this topic, you can see this YouTube clip right here. So it's important when we're doing clinical assessment that we're using normative methods. So this means that we're using assessments and frameworks that keep in mind the age, gender, and culture that we're assessing in. So we have to have an understanding of normal development for that particular subset of individual in order for us to understand whether what they're presenting with is normal or abnormal. And it's important for us to always be keeping in mind age appropriateness and the specific patterns of symptoms that we're observing. So the purpose of a clinical assessment is primarily to describe the symptoms that a child is coming in with. And so this includes behaviors, thoughts, and then also emotions or feelings. So those are the 3 main things we're assessing for the descriptive. The most important thing to think about in terms of assessing behaviors, thoughts, and emotions is to think about intensity, frequency, and severity. So if someone says, for example, their child tantrums once a week, you would want to know how intense that tantrum is. So you might ask a parent on a scale of 1 to 10, how intense does the tantrum get? You'd also want to know frequency. So I've been saying this in this example that this is a once a week problem. So it's very important to know how frequent the behavior, thought, or feeling may be, and then how severe of a problem that whatever that behavior, thought, or feeling may cause. It's important to assess when these things started and how long they've been going on. And it's important also to think about the symptoms and how they relate to one another. So for example, the tantruming only come up after a child has some OCD behaviors. So thinking about how all the symptoms are co-occurring in terms of their intensity and frequency. And so then we hope to derive a diagnosis based on the assessment. So we analyze all the information and we draw conclusions about the nature or cause of the problem, and we come up with our best estimate for a DSM-5 official diagnosis. Now in a clinic, you may or you may not do this. So you may do this for insurance purposes, Or if you're a school psychologist, you may do this for IEP plans for children in the school system. So there may be some sort of official or administrative reasons you might give someone an official diagnosis. In terms of just doing therapy, you don't necessarily need an official diagnosis to do that, and sometimes there are reasons, and we'll talk a little bit about this later, why people may or may not give a diagnosis in a clinical setting. So the thing that you would make sure to do when doing an assessment in a clinic would be to do a problem-solving analysis. So you want to make sure you're really focusing on areas of dysfunction and coming up with approaches that are going to address those specific areas of dysfunction. So instead of focusing on the diagnosis, you might focus on specific things that are going wrong in terms of behaviors, thoughts, or feelings, and ways. So another reason that we do an assessment is because people are often interested in the prognosis of their disorder. So the prognosis is basically our prediction regarding what's going to happen in the future. So we can tell people, based on data that we have, what will happen to their child if they don't do an intervention. We can tell them if these problems are likely to increase or decrease or just stay the same. And from that information, we can do some treatment planning. So we can use the assessment to generate a treatment plan with parents and families, and to think about how effective that plan is likely to be. We'll talk a little, I went backwards there in the PowerPoint. Multiple procedures in terms of using self-report and clinical interviewing, and also observation. And the things to keep in mind when doing an assessment are, who are you assessing and why? So for kids, this is really important because mostly a child is not the one who is requesting the evaluation. So usually when a child comes into a clinic, someone else has considered their behavior or emotions a problem, so not the child themselves. And so it's important to think about who requested the evaluation. Who is the person who's concerned about this behavior? Oftentimes it's the parent, it's sometimes teachers, sometimes a doctor has requested an evaluation. And you want to think about what their particular motivation may be for requesting the evaluation. So the things that we typically include in a clinical assessment are clinical interviews. We do self-report measures, so we'll have parents and kids fill out self-report measures, as well as sometimes teachers. And then hopefully we'll also do an observational assessment. So the therapist or clinician will oftentimes observe the child in a natural setting. So either go to their home, or go to the school, or go to wherever the problematic behavior is being manifested. And then sometimes if it is necessary, we will also do standard psychological tests, so IQ tests or other types of standardized tests to assess specific problems. So here's just an example of the components of an assessment that one might do. So one might administer the Achenbach Child Behavior Checklist, or the CBCL. That is something that parents and children and teachers can fill out. If we suspected autism, you might do this Autism Diagnostic Interview, the ADI. You might also do an observation. This is a very well-known standardized observation that there's extensive training for the clinician to complete before they do this, and it's called the ADOS. And so you would have the child come into the clinic, the child and parent come into the clinic, and you would administer the ADOS to get an observation of symptoms of autism. You might do this standardized developmental test, and then you might do a clinical interview with, in this case, maybe the grandmother, if the child spends a lot of time with the grandmother, and maybe it looks like Mrs. X is included here, so maybe the child's mother. And then you might do the Conners third edition, which is a report, self-report on child symptoms, and you might have the parent fill this out and the child fill this out. And then you also might do this Kaufman test of educational achievement. I'm assuming here in this case they might be looking for learning disabilities. So this is just giving you an example of the layout that a clinician might complete all of these things as part of the assessment to get a clear picture of what's going on with the child. And this can take anywhere between 1 session to maybe 4 or 5 sessions. So the assessment part of therapy can be pretty extensive. Here's another example of an assessment, or the different components of an assessment. So in this case, the clinician is doing a school observation of the child at elementary school. They're administering the self-report social communication questionnaire. They're administering the social responsiveness scale, or the SRS. They're also doing the social skills improvement system rating scale. And then they're doing a standardized psychological assessment test. The VABS, I guess is what that's called, the Vineland Adaptive Behavior Scales. So it looks like this child may be presenting in the clinic with some social skills deficits, and the clinician would be doing all of these different components to gain insight into what's going on with this child in terms of social skills problems. Oh, and this one also. So this is, the WISC is an IQ test, so it looks like this clinician may suspect that IQ level may be a problem, and so they're planning to administer the WISC to this child as well. Okay, so some things to keep in mind when doing clinical interviews as part of an assessment. It's important to think about developmental aspects of the child, so asking about, how did mom's pregnancy go? Did the child meet all their major milestones, meaning they were talking and they were walking as expected? Did the child have major medical problems? Are they on medications? Was their height, weight, and eating normal throughout development? And especially in child patients, it's very important to think about family characteristics, thinking about, is there a mental health history in this family? Is there a medical history? Is there a specific type of parenting style that may be playing a significant role in this child's psychopathology? For kids, it's also important to think about social history and social functioning. So getting a good measurement of interpersonal skills. How are their relationships going? Do they have close friends? Do they use substances socially? Are they getting in trouble at school? So getting a good picture of how they're socially functioning, and then also how they're functioning in their educational setting. So are they attending school? How are they doing? What's their GPA? Are they getting sent to the principal's office? Do they have special services or accommodations at school? So in terms of the types of clinical interviews that can be done, there can be unstructured clinical interviews, which is probably typically what a clinician will use in a therapy setting. And so this is where a clinician sort of has a guideline on what topics they're looking to address, but the questions are not specifically laid out. And when one is conducting an unstructured clinical interview, you can interview the parent and the child separately, or you can interview them together. It's important to think about their age and the child's age, and whether or not there may be confidentiality issues, especially if the child is an adolescent. They may not want their information shared with their parent, or if the child is very young, they may not be able to report on much of anything without the parent's assistance. And you must keep in mind that the information you're gathering may be biased, especially if the parent and child is in the room together. The child may not be being fully forthcoming with you about what they're telling you, and you may miss things depending on how you structure this interview. And so a structured interview is basically when you're asking very specific questions in a consistent and thorough manner. An example of a structured clinical interview is the CASADS. This is basically an interview that assesses for DSM symptoms in kids. This is especially important for research projects. So in my research, I administer the CASADS very frequently. And when you do the CASADS, you do the interview with the parent and the child separately, and then you come to some consensus about what they both told you. So when you're doing a clinical interview with a child, you're going to be asking specific questions that you're trying to get answers to, and depending on the child and their age, they may or may not be able to give you an accurate report on what's going on. But while you're doing the interview, it's also important to observe the child in the setting they're in. So to observe their thought processes. Are they clear? What's their affect like? What does their mood seem to be? What is their behavior in the interview itself? So for example, if you're trying to assess ADHD, you can observe whether the child is fidgety, whether they're able to sit in their seat. And while you're doing the assessment, it's important to build rapport with the child so that they feel comfortable with you, especially with young children. And so that to do that, a lot of times therapists will play games with kids, or they will chat with kids about things that they're interested in. But in general, I would say this is a pretty difficult obstacle for a lot of clinicians in terms of trying to relate to young children, trying to make them feel comfortable in their office, because oftentimes kids don't really want to be in a therapist's office. So doing behavioral assessments means that basically observing the child's behavior directly. So you want to be looking for things that are consistent with the parent report. And if when you do your observation, you see something that's completely opposite of what the parent is saying. So for example, if a parent is saying that their child has oppositional defiancy issues, and you observe them in the classroom and you don't see any kind of defiance and they're following the rules and they're very pro-social, you might start to think that this may be a problem between the specific parent and the child, and not necessarily a problem the child is experiencing across multiple domains. So this is the most important aspect of the assessment, I would say, is thinking about the ABCs of children's behavior. So this is called doing a functional analysis. So the A stands for antecedent. That means the thing that comes before the problematic behavior. Then the B stands for the behavior itself. And then the C is the consequence. So for example, if we had a child that had a lot of physical complaints, and the parents brought the child in and they said, this kid always says they have a stomach ache every day. We took this child to the doctor says there's no actual problem. So then you would do this functional analysis, and you would see, well, what comes before these physical complaints? So what happens before the child complains of having a stomach ache? And if you observed or the parents reported that usually right before the child has a stomach ache, the child has just been requested to go to school. So the parents say it's time to go to school, the child has a stomach ache, and then the important thing here is to think about, well, what's the consequence of that behavior? If the mom says, well, every time Billy has a stomach ache, he gets to stay home. Now we're starting to see that there's this pattern, there's a function to this behavior. So for Billy, the function of having a stomach ache allows him to be able to stay home from school. So he's being reinforced for having stomach aches. So some other examples here are problematic behavior of a child refusing to go to school. If you were to assess the situation and see that what comes before the child's school refusal is being teased, so maybe the day before the child was teased at school, that results in the child refusing to go to school, and what's the consequence of that? They get to stay home, and they don't have to be teased at school. So again, the school refusal is being, there's a good reason it's coming up, and it's also being reinforced. So then I'll just skip down to the last one. If another school refusal presentation might look similar at first to that first example I just gave you, but upon further assessment and doing a functional analysis, you may see that it's actually feelings of anxiety about going to school that drives this child's school refusal. And when they get to not go to school, their anxiety is reduced. So again, their behavior of school refusal is resulting in reinforcement via a reduction in their anxiety. So this is an example of a self-report, a very common self-report assessment that is done in clinical and research settings. This is the CBCL. And the CBCL is normed in a variety of ages and cultures and for different genders. And there are a number of subscales. So the first subscale is anxious depressed, the second one is withdrawn depressed, all the way through attention problems and aggressive behavior. And if you see here, this output will give you a normed range. So those two little dotted lines right here that go across the top between 65 and 70, that is anything underneath the 65 line is considered in the normal range, and anything above that 70 line is considered clinical range. And so the output from the CBCL will give you this sort of symptom profile where you can see which scales are elevated and which scales are not elevated for a child. The scales on the left are internalizing and the scales on the right are externalizing. So this child has a lot of depression, has some social and thought problems, but not a lot of externalizing behavior. So this is a pretty internalizing child. So psychological tests are sometimes given in clinical settings. So scores are interpreted in the context of other assessment information. So you would not have a clinician who would only do standardized psychological tests to do a diagnosis. They would always pair that with interviews and self-report measures. So some examples of types of tests that clinicians might do are intelligence tests or academic tests to look for learning disabilities, personality tests, neuropsychological evaluations, and projective tests. So classification systems for child psychopathology are basically systems representing the major categories of mental illness in kids. So there is no single agreed upon worldwide classification system for childhood disorders. We do have a few different options. So the DSM-5 is primarily categorical, although there are some severity ratings which can be viewed as dimensional ratings of symptoms. And in general, dimensional systems are better for research purposes because they are more fine-grained assessment, but categorical assessments or diagnostic systems are easier for clinicians to communicate about. So it's easier for me to say to you, as a clinician, to another clinician, oh, this child has ADHD, instead of saying something like, this child is elevated on attention subscale about being forgetful at a 7 out of 10, and elevated on impulsivity subscale of blurting out answers in class at a 6 out of 10. So that would be a lot to talk about. So using these categories for diagnoses can be sort of a good shorthand for clinicians to communicate about kids' problems, and also can be easier for treatment planning because we can kind of lump kids into a category and use treatments that have been useful for those kids in the past. The history of our diagnostic system for psychological disorders begins around 1948, where the International Classification of Diseases added a section on mental disorders. And then in 1952, the American Psychiatric Association, or the APA, did develop the first DSM. That was the DSM-1. In this DSM, the children and adolescents were not included at all. So in 1980, the DSM-3 was created, and this focused more on observable symptoms. There were diagnostic criteria involved, and there were some child categories in the DSM-3, although not many. The emphasis in the DSM-3 was on context. You didn't, and in the DSM-3, you didn't have to have all the criteria to actually get a diagnosis of a disorder. And then in 1994, the DSM-4 came out, and then our most recent diagnostic and statistical manual, the DSM-5, came out in 2013. It's still not developed, but other than those, other than these disorders, the DSM doesn't take development much into account in terms of psychopathology. So criticisms of the DSM-5 include not focusing much on development or childhood, a lack of emphasis on the context in which certain behaviors or emotions or thoughts are being elicited. There's this issue of some kids not meeting all diagnostic criteria, even though they are having dysfunction, and they may therefore be unable to get services. There's limited validity to the childhood disorders in the DSM-5. And right now in the DSM-5 and also in psychology at large, disorders are defined based on observable symptoms. So at this point, we're not defining disorders based on the underlying cause of the disorder. we are just sort of saying, oh, well, you exhibit these symptoms, so therefore we're going to give you this disorder, which has major problems, which is where RDoC comes in. So RDoC is the Research Domain Criteria Initiative created by NIMH. This proposition, or this priority, the RDoC initiative, is the purpose of it is to classify mental disorders based on their biological origins. So instead of classifying disorders based on symptom presentation, RDoC's goal is to classify disorders based on what's going on in people's bodies and brains when they're having these disorders. So the goal of RDoC is to develop a future classification system that will be based on research findings, and these focus on domains of functioning that map onto underlying pathophysiology of different disorders. So for example, one of these domains is cognitive systems, another is negative valence systems, and these are broken down into domains like attention, and then further broken down into units of analysis. So for each domain, you can have the genetic aspect of that domain, or the molecular aspect, or the neural aspect, or the behavioral. So there are these different units that RDoC focuses on. So here is an example of an RDoC matrix, and I wanted to point this out because the error-related negativity, or the ERN, is included in this matrix, which is what I study and I've talked a little bit about in this class. And so this domain is the negative valence system. The specific construct is sustained threat, and you can see in this matrix that all of these units of analysis are designed to measure threat. So if you look at, there's no genes listed here, but molecules, well, there's not much information here, they're just referencing an article. But on the cellular level, they look at hippocampal arborization. Then there's the circuit level dysfunction, so they look at cingulate reactivity or amygdala reactivity. And then the physiology domain, we have HPA axis, which we've talked a little bit about in the ERN. And then we have behaviors in the threat context. So we have conflict detection, attention bias to threat, helplessness behavior, punishment sensitivity, avoidance. And so basically the idea behind RDoC is that we will use research to fill in these matrices so that we can, at some point, use these different measurements to define psychological disorders and to do assessments based on these measures. The RDoC approach, the idea here is that this approach may eventually displace our current classification systems. We may in the future use lab-based approaches to diagnose psychopathology. So currently we don't use lab-based approaches. We just sort of ask people about what's going on. So we do these interviews, we do self-report, we do observations, but we're basically observing emotional and behavioral dysfunction. In the future we may use lab-based approaches. So we may put someone in a scanner and measure their amygdala reactivity to something in order to diagnose what's going wrong in their brains. At this point, RDoC is in its very preliminary stages. It remains to be seen whether this approach is actually going to work for clinical diagnosis purposes or for treatment. Okay, so as of right now, we are not using the RDoC approach in clinical settings to diagnose mental illness. We are using, for the most part, DSM categorical labels, and so there are some pros to using these labels. Like I mentioned before, using diagnostic labels facilitate or help communication between professionals. So mental health professionals know what these labels mean, and they're able to quickly understand what you're trying to communicate about a patient. These labels or diagnostic categories can also help us do research about causes, epidemiology, and treatment. So, for example, to do epidemiological work on dimensional symptoms is much more complicated than to do epidemiological work on categorical diagnoses. So it's just a much more complicated endeavor to try to integrate individual symptom scores into researches about underlying causes and prevalence rates. So some cons to using these diagnostic labels It's debatable whether it actually helps communication. So while a clinician may understand right away when you say this child has ADHD what you mean, they may also have a lot of assumptions that go along with that label that may or may not be accurate. So in some cases, we may actually be miscommunicating by using these labels, and the same can go for research. So for example, two people can have a diagnosis of depression, but actually be having a completely different experience and presentation, or a very different experience or presentation of that disorder. And so by lumping them all together into this one category of depression, we may actually be hindering research. And then there are also effects on individuals of labeling. So we know that when we tell people that they have a diagnosis like ADHD or depression, they may start to actually experience and behave differently in terms of sort of fulfilling a self-fulfilling prophecy of living out that whatever the associations they have for that diagnostic label. So in terms of intervention for treating childhood disorders, we try to use problem-solving strategies that target whatever the current problems are that the child is facing. And then we want to also think about the maintenance of our treatment effects. So we don't want to come up with treatments that may work in the short run but won't work in the long run. We want to be able to prevent future problems. And so our treatment goals include positive outcomes related to the child, but also the child's family and society in general. There are some ethical standards to keep in mind when thinking about treating childhood mental illness. So we want to make sure that we are always selecting the appropriate treatment and selecting the appropriate treatment goals that are in the best interest of our patient or client. We want to make sure that participation in the treatment is voluntary. So sometimes this is tricky with kids who don't believe they have a problem. So there is definitely an amount of work that goes in the beginning in terms of making sure everyone is on board with the treatment. It's important for us to document the effectiveness of treatment and keep good records about what happens at treatment, and also protect the confidentiality of the client. So in most cases, like we talked about with research, it's similar for therapy clients. Most information is kept confidential unless we hear about intent to harm oneself or someone else, or abuse. And then you also want to always be keeping in mind the therapist's qualifications and competencies. So if, for example, you're a therapist who has never treated a child with OCD, and that child comes into your clinic and you feel like maybe you've never been trained or supervised in treating that particular disorder or anything similar, it may be in the client's best interest to tell that client you don't have the competency to treat this particular disorder, and you may want to provide referrals. So there are a few different approaches to treatment. There's psychodynamic, behavioral, cognitive, behavioral, client-centered, family, and neurobiological approaches. So I'm going to go through each of these briefly. Psychodynamic approaches focus on resolving underlying unconscious and conscious conflicts. So the treatment is very much focused on developing awareness of these underlying conflicts. This is not something I've been trained in, and is not the standard treatment currently, so we're not going to talk too much about this. Behavioral treatments are, however, the standard approach to treating abnormal child behaviors. So basically, like we've talked about, the behavioral perspective views problematic behaviors as being learned through operant or classical conditioning, and the treatment emphasizes basically a re-education using behavioral principles to alter the problematic behaviors that the child is experiencing. Cognitive treatments are focused on problems due to distortions in thinking. So the treatment works to change faulty cognitions, which, depending on the age of the child, may or may not be useful, because some kids are too young to be able to work with them on their thinking patterns. So one of the most standard ways that we treat childhood mental illness is through a combination of cognitive and behavioral approaches. So basically, this is just combining the behavioral and the cognitive approaches that I just described. So problems are seen as the result of faulty learning experiences and also environmental experiences, Treatment focuses on changing these maladaptive cognitions or thoughts, teaching behavioral coping strategies, and also self-regulation. So you see this triangle at the bottom of the screen. Cognitive behavioral therapy, or CBT, focuses on this triangle quite a bit. So you seek to identify the thoughts that are maladaptive in the patient, the emotions that are related to those thoughts, and the behaviors that are related to those thoughts and emotions. And it's thought that these thoughts, emotions, and behaviors are all impacting one another in a way that makes it important that we intervene on all aspects of the problem here. There are other treatment approaches. One is client-centered. Under this view, problems are the result of environmental and social demands that are being put on the child. So the main role for the therapist in this type of therapy is to provide unconditional, non-judgmental, and genuine acceptance. So they don't work a lot on problem solving in this type of therapy, but just on the sort of acceptance of the child. This is also pretty unusual these days. There are family models which view children's problems as a manifestation of basically problems in the family. So right now, if we were to bring a child into a clinic, a good clinic that was evidence-based, it would most likely be a combination of a family model perspective with a CBT model. So it would be looking at family dynamics as well as looking at cognitive and behavioral problems associated with the psychopathology. And so it would be an integration of family models, cognitive approach, and behavioral. And then there's also this approach. So the neurobiological approach is basically using pharmacological and other biological approaches to treat psychopathology. And this is also a very common way of treating mental illness in kids these days. In terms of treatment effectiveness, best practice guidelines suggest that we use approaches that have been shown in evidence-based trials, or RCTs, to be effective. So these best practice guidelines are published, and clinicians are supposed to use these guidelines for treating patients. So it's not the case that as a therapist, when a patient comes into the clinic, you just kind of decide whatever you feel like in terms of treating that patient. You should consult these guidelines and use evidence-based treatments to, if there are any, to treat kids who come into the clinic. So EBTs, or evidence-based treatments, are basically controlled studies in large-scale clinical trials that have demonstrated effectiveness. And then if whatever the child is presenting with, there is no EBTs appropriate for that particular issue, which happens quite a bit, you would want to use this expert consensus approach, which means that you're basically filling in the gaps with what we do know from evidence-based practice, but also with knowledge from the opinions of experts and other clinicians who have treated similar conditions. So you're kind of combining this evidence-based approach with your clinical judgment. So these are some organizations that publish these best practice guidelines. So the Society of Clinical Child and Adolescent Psychology publishes best practice guidelines, as well as the American Academy of Child and Adolescent Psychiatry. And here are the links to those in case anyone is interested. So overall, the good news is that kids who receive therapy do seem to have more positive changes than those who do not. Treatments have been shown to be pretty effective for internalizing and externalizing disorders in kids. And treatment effects do tend to last for a while, so for up to 6 months. The field has demonstrated efficacy in terms of treatment outcomes. So there is some bad news regarding treatment for kids. It seems that most kids who need treatment actually don't end up, actually that's my next point. My first point here is that fewer than 20% of treatments demonstrate evidence that they actually reduce impairment in life functioning. So these treatments may reduce symptoms, but they don't often, as they stand now, actually help kids function better in life. So there are positive changes associated with these treatments, but one could sort of speculate that these changes may not be meaningful in the long run for these kids. Another negative side of intervention work in kids is that a lot of times, for some reason, when we do therapy in a research setting, we get different outcomes than when community therapists administer therapy. One reason this could be is that in a research setting, there are a lot of really strict guidelines on how the therapy is being administered, and there's a lot of people watching videotapes, and there are manuals, and everything's there's a protocol for how to run the therapy. And that is pretty different than how it typically happens in a community setting where therapists may not be fully or appropriately trained on that intervention, and they may not be administering it reliably. So that's one reason why outcomes may be different. Another is that samples that are recruited to research-based settings may be different than the samples that generally present in the community. Studies on clinical therapy in the community have often resulted in minimal effects. So that's pretty bad news in terms of how well are we doing in intervening. In terms of community therapy, it doesn't seem like we're doing that well. And then this was the point I was making before. So most kids who need services actually don't ever receive them. So the estimate is between 70 and 80% of kids who actually do need psychological intervention aren't getting those interventions. So one of the main issues for us as clinical therapists and researchers is to figure out how can we better disseminate the interventions that we do have.